The scientific agenda for the 2025 NEI Spring Congress will cover everything from traditional medications to what's new on the market now, filling any gaps in your education as well as new developments. Register now for our popular spring event being held May 8th through the 10th in person in the city of brotherly love, Philadelphia, which is also the city where I was born and raised, my beloved hometown, and via simulcast online. Secure your spot today at nei.global/SP Congress 25A. That is nei.global/SP Congress 25A.
Welcome to a special Pediatric Psychopharmacology series of the NEI podcast, hosted by Dr. Jeffrey Strawn. Dr. Strawn is a professor of pediatrics and psychiatry and behavioral neuroscience at University of Cincinnati College of Medicine, with expertise on mood and anxiety disorders in children and adolescents. In this series, he will engage with fellow experts to discuss important issues related to pharmacological treatments for psychiatric conditions in pediatric patients.
Hello, I'm Dr. Jeffrey Strawn, and welcome to the Pediatric Psychopharmacology series, incorporating CBT into the MedCheck. It is my pleasure to be here with my good friend and colleague, Dr. Katherine Dahlsgaard. Dr. Dahlsgaard is a licensed clinical psychologist who has extensive expertise in CBT for children and adolescents as well as adults. She specializes in evidence-based assessment and treatment of anxiety disorders and related conditions, and I'm excited to ask her some of my more difficult questions about how we can incorporate CBT or CBT principles into the MedCheck. Welcome, Dr. Dahlsgaard.
Thank you very much, Jeff. I'm delighted to speak about those things with you.
So let's dig right in.
Let's do it.
Tell us, what are the benefits of integrating CBT into, a medication management appointment in a child or adolescent patient?
I think that there are several, and I'll go through them one by one. So the first is that we have two good, well-established treatments for, I'm going to say CADS, child anxiety disorders. And one is the SSRIs, and the other is CBT. So we have a good medication, and then we have good psychotherapy, and a specific psychotherapy. And they work in tandem quite well, and we know that from the randomized controlled trials that have been done. So for instance, in CAMS or POTS with OCD, combined treatment tends to do better than either the single treatment, CBT or SSRI alone. However, both SSRIs and CBT work quite well for child anxiety disorders. So I think part of what works great when prescribers, psychiatrists, nurse practitioners talk about CBT principles and in fact demonstrate them with the child during the MedCheck is that they are supporting another evidence-based psychotherapy. So, and I know that in my own work with children, I see them and I do CBT. I don't prescribe medication, but one of the things that I do quite often is say, reinforce for them that if they're taking medication, there's a good evidence base behind that. So I support psychiatrists' work, nurse practitioners' work, and I like when psychiatrists and nurse practitioners, other prescribers, support my work for the child. So I think that's quite reassuring both to children and parents. The second is just generalization of skills. So CBT for any disorder, but anxiety disorders in particular, is about learning skills. And I think that the major skill that kids learn, hopefully in CBT, is how to function while they are anxious, right? That's the whole purpose of exposure, whether the exposure is to petting a dog in the case of dog phobia, or saying the word vomit in the case of my vomit phobic kids, or tolerating going upstairs and going to the bathroom by yourself and not making a parent come with you in the case of my separation anxious kids. We want them to learn that they can function even when they're anxious, right? It's one of the core principles and core skills that kids learn in CBT. And the more places they learn that, not just in a therapist's office, not just with me, but then during CBT homework, in the places they really live, right? So at home, out in the neighborhood with dogs, those skills generalize. And then to have another authority figure and another caregiver meaning the prescriber, then reinforce those lessons adds even more weight and more generalization of skills.
So in other words, it sounds like we can get a more synergistic effect in terms of that reinforcing and repetition that comes with incorporating some of these CBT practices into the med check.
Yes, the more repetition, the better the learning typically.
Interesting. So, speaking personally, when I was in training and, even adult psychiatry training, but also in fellowship, I was told that exposure-based CBT was really difficult. You needed to establish this fear hierarchy. You needed to figure out this system by which we were going to measure these subjective units of distress, and you needed to prepare the patient prior to an exposure. You maybe needed to do an imaginal exposure before the actual exposure. And then there needed to be this extensive debriefing, and I was incredibly intimidated. Is that still the way it works, or is that a bit outdated?
Is it outdated? Look, Jeff, I'll be honest. I would love to say that what you just described is exactly what I do, meaning it's complicated and it's hard, and I was trained within an inch of my life to be this top exposure therapist. And all those things are true, of course. Of course they are. However, it is also the case that there is a fundamental principle at work. And again, I will say it again, and I'll say it maybe 60 more times during this podcast. And that is that the more that we encourage people who suffer from anxiety to practice functioning while they are anxious, the bigger their life is going to be. So anxiety disorders are maintained because kids and grown-ups, right? So kids and adults, it doesn't matter, begin to over-rely on avoidance of safe and healthy things as their main means of coping. The avoidance is driving the anxiety. So the more you avoid dogs, the more you avoid saying the word vomit, the more anxious you're going to be about dogs, the more anxious you're going to be that vomiting is the worst thing that could happen to you, right? And I treat dog phobia and vomit phobia all the time. So the fundamental principle of I can function while I'm anxious does bring new learning and a sense of resilience, but also typically decreases anxiety. So does any person during a med check have to be a top-notch exposure therapist? Heavens no, it doesn't need to be intimidating. Rather, if you keep in mind that fundamental principle, whenever I can get this child to practice even more functioning while they're anxious, the bigger their life is going to get, right? Because over-reliance on avoidance leads to a smaller and smaller life. So does it need to be complicated? No. What you are demonstrating and teaching a child or having them practice during a med check, if you can get them to say the word vomit because they were busy saying, I don't want to say the word. And you say, well, then just whisper vomit. And the kid says, no. And you say, okay, look, I'll say vom and you say it. Here we go. Vom.
It.
Vom.
It.
I'll say vomit. You say vomit. I'll say vomit. You
vomit,
say
vomit.
Vomit. Vomit. Oh, you said it. Okay, now a little bit louder. Vomit.
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 Vomit. Vomit.
Okay, good. All right.
We did it.
And I
can say it.
Okay, wonderful. All right. So that was not particularly complicated. It was playful. It was sort of fun. But that's the principle. And what you were teaching is a life lesson. And that life lesson is when you do it, when you do the thing that you're afraid of, the thing that's safe enough, and you do it even though you're afraid, your life gets brighter and bigger.
So I love it, but let's take it to the next level.
Let's do it.
So I get these kids in my office, and as we're talking about those things that they avoid, and we start talking about X, Y, or Z, I just won't be able to do it. I can't do it. What do you do? As a prescriber, as a psychiatrist, how do I handle that using the CBT principles?
Yes. Well, the way I would recommend not handling it is what I call therapy through telling, which works about as well as parenting through telling. And that is, oh, well, you should totally do that. Okay, next.
That doesn't work?
No, apparently it doesn't. It's never worked for me, unfortunately. So my patients get better when I say, hey, you know what? Let's do it right now. So let me give you an example of where it would be appropriate in the med check. So you have a kid who says, you know what, you say, this is a kid who's socially anxious, a teenager, and you say, I want you to be kind of initiating more getting together with friends, because a lot of my socially anxious teens, they'll always respond to an invitation if a friend has given it, but they're too afraid to initiate it, because they're in the back of their mind, they're always kind of over predicting that they're going to be the object of negative evaluation, right? So if I invite, they're going to say yes, but only because they're being nice. So you have those kids, and during a med check, you can, when the kid says, I just can't do that, I'm too worried about it, that is a great time to say, you know what, let's do it in the office. Pull up your phone, open up Snapchat, who's your best buddy? Give me her first name. Her first name is Daffodil. That's quite a name. Great. What do you think? What do you want to do with Daffodil? You want to go to the mall with Daffodil this weekend, or, hit up Lululemon, get some Lulus? Excellent. Why don't you... and have her do it, and then have her show you the phone, and then high five her when she does. Great. You just did an exposure with that kid. Another example might be the kid who is so withdrawn and depressed. It's been so long since they felt good. And they just say, I just am going to go home and go to bed. I know it. I'm just going to be scrolling. I'm going to just be scrolling until I die. That just like an incredibly withdrawn kid. All right. Hey, you know what? It's a great exposure for depression and withdrawal. Let's take a quick walk around the block. Let's walk around the block and we can talk about this. And you can do a med check as long as you're preserving privacy with a brisk walk around the block. That is an exposure. Is it going to change the child's life? Not necessarily, but it is another brick in that wall of building mental health.
So what I'm hearing also is that we just need to be really flexible in terms of how we think about these exposures, that this is not the classic thing that we would do with spider phobia, where it's graded exposures and really deconstructing expectations and, looking at the cognitive aspects of it. I hear that this is much more behaviorally oriented.
Yes, definitely. I think doing in session is great. So, for instance, spider phobia, you have a kid who's terrified of spiders and is working with their cognitive behavioral therapist on actual exposures to spiders. You can, as a prescriber, turn around, pull up a rando spider video on YouTube and have it playing in the background while you're doing the med check with the child. And then every so often you can turn around and say, you know what, I really like that spider. He looks like a good one. Let's name him real quick, right? So you can actually be quite playful. Now, what you're doing there with the child is you're getting them to look at the spider and come up with a name. So remind me, it's over my back of my shoulder. What color is that spider? Great. So what like a green and yellow spider, what do you think his name might be? Corny. I like that. All right. Again, that is an exposure, even if it's playful and a little humorous. And it's much better than saying, I think, oh, well, keep working with your CBT therapist.
Right.
Yeah, and it took you all 15 seconds to pull up that YouTube video.
So I like this, but it's great for social anxiety disorder. I can see it for separation anxiety disorder. I can see it certainly for specific phobia, although quite frankly, most of our patients don't come to a medication-oriented visit for a specific phobia. But what do you do about that patient with generalized anxiety disorder who comes in, and as you're asking about the insomnia, as you're asking about the tension, the restlessness, all those DSM symptoms, and then you start talking about the specific anxiety and worries, they say, but I worry that I'm going to fail because I know I'm going to fail. And I worry that bad things are going to happen. And I worry about my health. How do you design an exposure? Or is that a situation where you focus on the cognitive? What do you do?
In the case of those worriers, those anxious Annies and those sort of, kind of nervous Neds, what I like to do with them is as follows. I like to think, what is maintaining the anxiety? And typically what's maintaining the anxiety is some form of avoidance. In GAD, what we frequently see with kids is that they are over asking for reassurance. So they're asking their parent, are you sure that the stomach ache doesn't mean that I'm going to be too sick to go to school tomorrow? Or the opposite, are you sure that the stomach ache isn't bad enough, you're going to make me go to school tomorrow? And they'll ask parents over and over. And I will say to parents, the information seeker asks the question once and then they're satisfied with the answer. The anxious excessive reassurance seeker is going to be asking you over and over. So one thing that I do in my sessions with GAD kids, these worriers, is I try and let them know I'm not going to give them excessive reassurance. So with the younger kids, if they ask me, or during a med check, if they say, are you sure this medication is going to make me feel better? And you say, well, I don't know, but here's the evidence base behind it. And then later the child says, but is this going to make me feel better? And you can say, again, playfully, this isn't Frost and Nixon, right? You don't have to get them to agree with you, but you can say quite playfully, oh, you know what? That sounds like you're asking, worry's probably asking me that question because you already asked me that once and I answered it. So you know what? I'm not going to answer it again. Let's move on because I think worry's trying to get you preoccupied. So that would be a quick example where you say, you point out the request for excessive reassurance and then redirect the child.
That's great. So what I hear you saying is that those anxious thoughts, those worries are really connected in some way with some behavior, or in essence that the anxiety is sabotaging or getting in the way of some other aspect of functioning, whether it's the relationship with a friend, whether it's the relationship with a parent, whether it's sitting down to do the schoolwork or the homework or something else. And so you're really identifying still a behavioral target. And one of the things that our listeners may not know, but which I've heard you say many times, is regarding CBT, if you do the B, you get the C for free. Tell us what you mean when you say that.
Yes.
Because I think it applies here.
Very, very much. So CBT is a multi-component therapy, and it's typically composed of teaching relaxation, cognitive identification and modification, and that is helping kids to figure out that they're having catastrophic thoughts and then bossing back those catastrophic thoughts, and then exposure. And the definition of exposure is gradual, strategic exposure to the safe enough thing that is being nonetheless avoided. Originally, we were trained in the manuals to start with the cognitive stuff and actually start with the relaxation, then do the cognitive stuff, and then only after maybe 8 to 10 sessions had passed, start with the exposures to prepare the child. What dismantling studies of the last 15 years have showed is that first, exposure is the active ingredient of CBT. It soaks up the major what research studies have shown us in the last 15 years, the dismantling studies, is that exposure is indeed the active ingredient in CBT, and it's the ingredient that soaks up the variance in treatment outcome. So the more exposures you do, the better the kids get.
So what I'm hearing you say is maybe we shouldn't wait until we're into session 8 of seeing a patient before we start doing or thinking about doing exposures. When do we do them?
I think that exposures can be done during the intake. Exposures can be done in session 1. So again, in the intake, if you have a kid, vomit phobia is the one I keep coming back to, but who doesn't say vomit phobia in the intake, you can do what we just did in the intake, meaning play the vomit game where you whisper vomit and then you say it loud and then you end up singing about it and then you're skipping down the hallway back out to the waiting room talking about vomit.
But some of our listeners are going to say, Dr. Dahlsgaard, what if that patient becomes anxious in that first appointment with me and potentially doesn't come back or is too afraid to come back because I've pushed too hard?
Oh my goodness. Well, I think that those listeners are listening to one of the 3 big lies of anxiety. Do you want to hear about the 3 big lies of anxiety?
I do want to hear about the 3 big lies.
Who doesn't want to hear about the 3 big lies of anxiety? So these are the 3 big lies of anxiety. Anxiety is so predictable. It's almost soothing, except that we're talking about anxiety, so it's never soothing. The 3 big lies are as follows. Anxiety always predicts a negative outcome. So no matter what you're thinking, if you're thinking about doing an exposure with a patient, anxiety is never going to say, it'll go fine, you're teaching a life lesson, don't worry about it, get them to function while anxious, and then send them back out to the waiting room and call yourself a great prescriber. Anxiety is going to say, you're going to break this child, it's not going to go well, you're going to make them anxious. The second big lie of anxiety is not only is something negative going to happen, but it's also going to be a catastrophic outcome. So anxiety is not satisfied when it's merely, sort of you get a C on the test that you were dreading. Anxiety is always going to tell you, it's not only is it going to be a C, it's going to be an F, and the teacher's never going to forgive you. So in the case with this kid, it's going to be, I'll break the child, they're going to get too anxious, and also they're never going to come back, and I'm going to be the one that's responsible for having that kid never get treatment. The third big lie of anxiety is that anxiety will get you to underpredict your ability to cope in the outside chance that all those negative things do occur. So what happens if a child gets anxious when they're coming to see you for treatment for an anxiety disorder? First off, how much more anxious are you going to make them? They're already anxious. At least the kind of anxiety that they have when you're doing a little mini exposure with them is productive anxiety. So they're not avoiding. When they're with you, they're actually doing something. And the other, I think, is to be super positive with kids, which is when they're anxious, you don't treat it like a tragedy. You can say to them, great, look, I made you anxious. That means you're getting better. All right, great. So I think being quite positive and quite confident is the child and the parent will pick up on that.
So let me just recap those because I think they're so important. Lie number 1, there will be a negative outcome. Mm-hmm.
Test anxiety, dog anxiety, separation anxiety.
Generalized anxiety disorder.
Whatever it is, my parents are going to go away. I'm never going to see them again.
Lie number 2, that negative outcome will be catastrophic.
They're going to be kidnapped. I'm going to be kidnapped. It's going to be terrible.
Lie number 3, I am completely underestimating my ability to cope with any negative outcome.
Yeah, I don't see my parents for an hour or two while I'm at school. Probably I'm going to be anxious at school, but you know what? I'll probably be fine because I'm going to be crying at school and I'm not going to be able to manage it, and so I better stay home.
So as I'm thinking about these 3 lies, you know where my mind is going?
Is it getting anxious?
No. Well, maybe it is, but I'm thinking about those discussions that I have as I'm starting medication, right? Because oftentimes for me, the patient's been in therapy, the therapist or psychologist has referred the patient to me. We've had some discussion about potentially there's a role for medication here. I bring them in, I do an assessment, I talk to the family, I talk to the patient, and then we start talking about medication. And oftentimes, I see these same 3 lies come up over and over and over again as we talk about medication. What advice would you give to me and would you give to the listeners in terms of how to use these 3 lies or even just your general CBT approach to talk about medication in these situations, particularly around anxiety disorders?
Yes. Well, if you are prescribing medication for an anxiety disorder, you can expect that the child and quite potentially the parents as well are going to be anxious. So the child, and again, often the parents who are anxious, often anxious themselves, typically aren't going to say, oh my gosh, medication, great. This is going to have a great outcome. Wow, look at those effect sizes in the randomized controlled trials. Medication is for me, right? They're going to be overpredicting a negative outcome. This isn't going to work, or this is going to take away my child's essence. There's going to be too many side effects and my child won't be able to tolerate them. The catastrophic outcome can be things like my child will be a zombie, my child will never recover, my child will be on medication for the rest of their life. And then the kind of overprediction of inability to cope and then I'll be helpless. And what I talk about with parents and with kids themselves is being flexible. So let's try it and find out what happens. Because I think anxiety's got you here, and it's only letting you think about the potential negative outcomes and not any of the neutral or positive ones. So what would you say to the parent whose first response to you when you mention medication is, will this take away my child's essence? I don't want to have her be on medication because another child that I know took it. She became a zombie. She was a different child. no, I'm afraid that will happen to my child as well.
So for me, and this may deviate a little bit from the CBT approach, but part of this goes back to some earlier family therapy training for me. So I would join in terms, and really it's a genuine joining. I don't want this medication to take away your child's essence. And really what I would do at that point is actually explain what I want the medicine to do and what we mutually hope that the medicine will do. And for me, that's a situation where I think some reframing and maybe some general psychoeducation is helpful. And I think in that situation, I will often say, this is not a medicine that takes away all anxiety. I still want you to be anxious when you're getting ready to take the SAT, before you take your driver's test, before you go on your first date. Again, depending on, the developmental stage and so forth. I also emphasize that I don't want this medicine to take away normal sadness. Anxiety and sadness are normal human emotions, and I think that's something that's really important. So I really emphasize that I don't want this medicine to change who the person is. I want it to take away the anxiety that is related to an anxiety disorder, if you will, that anxiety that's related to social anxiety disorder that is functionally impairing, or that's related to generalized anxiety disorder, or panic attacks that are causing profound functional impairment. I think the other thing that comes up for me is when we're talking about some of the more common side effects. So things like the gastrointestinal symptoms or the nausea that sometimes happens when we start the SSRIs. And I think two things for me really come up. And as you were talking, I was thinking about the lies of anxiety. Because when we talk about the perhaps nausea that sometimes happens when we start these SSRIs, it really goes to lie number 2 and lie number 3, right? So if I have nausea, I will be vomiting in school, I will not be able to go to school, and it will persist forever and ever and ever and ever. And there is nothing that I will be able to do to cope with it. So I think some reframing in terms of what we know about the nausea. So we know, first of all, why the nausea happens. Well, these medicines are increasing serotonergic tone. Serotonin is the main neurotransmitter in the gut that controls GI motility. So the SSRI is really doing the same thing in the gut that it's doing in the brain. The other thing that we know is that these effects are transient. Most of the time, they've gone away within 3 to 4 days after starting an SSRI or after a dose increase. So I think also that knowing that there's a consistent temporal profile is helpful, because I think, and we can talk more about this, there's often that intolerance of uncertainty that goes with these anxiety disorders. And I think that particularly comes to a point when we think about side effects, right? Will I get the side effect or not? How severe will the side effect be? How long will the side effect last? Will it ever go away? Will it come back? Will there be any warning as to whether it comes back? What advice would you give me as a psychiatrist prescribing these medicines as I talk about these side effects from a cognitive standpoint?
Well, from a cognitive standpoint, I wouldn't even argue from a cognitive standpoint. I would say that what you are doing there with the child is you're doing an exposure. And the exposure is to taking the medication and finding out. When I hear kids do that thing, right? Anxiety never says, you're going to feel a little barfy and then it'll go away and it won't bother you that much. And then you'll forget about it because it goes away. And also you're going to feel less anxious, right? Anxiety never says that, ever. It is always that rigid all or nothing thinking that happens when we get anxious, right? Our brain goes to all or nothing. And so one of the things that I do is I will turn to the parents while the kid is right there and say, we're going to talk about you. I can know that you can listen. So mom and dad, what's going on here is I am asking your child to be a little bit flexible. And we are going against what anxiety wants. And what anxiety wants is it's either got to be perfect or it's going to be terrible, but it can't be anywhere in between. And I won't be able to tolerate managing the discomfort until it gets better. So in fact, this is a great exposure. And if you don't like the medication, you don't have to continue taking it, by the way. So we can all be quite flexible here.
I love it.
Yeah, I do too.
Let me stay with this medication theme. And I'm going to really tie this in with exposures, which, up to this point we've been talking about as being really important, but they do come with some distress. And if I'm hearing correctly, we want some distress. We want some anxiety associated with those exposures. Now, certainly in our psychopharmacologic tool belt, we have medications that acutely can reduce anxiety. We have things like antihistamines, hydroxyzine, etc. We have things like benzodiazepines. We don't use those as much in pediatric patients, as you know, but we do have these medicines that can acutely take away anxiety on a PRN basis. Now, I've seen some people use those prior to a situation that would be expected to bring on anxiety. I'm really curious what your thoughts are on that. Is that something that we should do, we shouldn't do, or it depends?
Yes. Typically, I will leave it up to the prescriber and support whatever the prescriber has done. However, part of life is learning how to function when one is anxious. So I don't really have a problem with infrequent use of, let's say, benzodiazepine. I have many friends that will pull me aside and tell me what their specific plan and dosage is for getting on a plane, but they don't fly all that often. So fine. But if you are relying too often on a PRN anxiolytic so that you don't feel anxiety, the message that you are giving yourself is, I couldn't function while I was anxious, so I need this to function. And I prefer to help my patients, be they kids or adults, start to wean down on those and use them less, because ultimately they are safety behaviors, right? So taking these anxiolytics are safety behaviors. And for my listeners, safety behaviors are things that we do to keep ourselves safe, and I'm putting quotes around safe, around things that aren't dangerous. So feeling anxiety is not dangerous. It feels dangerous, but it is not dangerous. You can do all sorts of things while you are anxious. You can drive a car, you can take a test, you can go on a date. It's not dangerous to be anxious, and therefore, we want you to know that you can live your life even during a time of quite high anxiety. To answer your other question, yes, exposures are supposed to be distressing. That's the very nature of an exposure. So when kids get distressed in my office with me during sessions, I actually will say, that's great. We know the exposure is working. Oh my goodness, you're so anxious. That means that your amygdala is busy predicting the worst outcome. And then when that doesn't happen, gosh, you're going to learn a lot. So we know from research, and this is Michelle Krask's research on inhibitory learning, that the higher the distress, the better the exposure. So high distress is to be embraced because, again, high distress in itself is not dangerous.
Katherine, I want to stay with this theme for a minute here as it relates to these PRN medications. Mm-hmm. And I like this idea of the inhibitory learning, and I think this relates also to something else from Michelle Krask, which is that idea of violation of expectation. Can you briefly just walk us through that process? And then I'm going to ask another question about how that relates to these PRN medications.
Absolutely. And by the way, violation of expectation, isn't that terrifying?
Oh, yeah. It scares me.
Yes, it sounds like...
I don't like being violated. Violating is bad, right?
Violation is terrible, and I like my expectations. Look, listeners, let's discuss. What we're talking about here is when you have an expectation that is lie number 2 of anxiety. The expectation is catastrophic outcome. So for my kids who have food allergies and they have incredible anxiety about their food allergies and they're afraid to be in the same room with someone who's eating peanuts, we will do an exposure where we will have them sniff peanuts. This is absolutely safe. There's a randomized controlled trial showing that this is safe. And their expectation is, if I sniff these peanuts, oh my gosh, I will go into anaphylaxis. The more they believe this, the higher their distress ratings. So you mentioned SUDS earlier, subjective units of distress, 0 to 100. They'll say, I am a 100, Dr. Dahlsgaard. I am going to sniff these peanuts, because they have this high expectation. When they then sniff the peanuts, we sniff them again, And then we set the timer for 5 minutes and hang out and find out what happens. And what happens is they get incredibly anxious, and then we're hanging out, and then we're hanging out, and then they don't go into anaphylaxis. That is the good kind of violation of expectation. It's the expectation was problematic. And then I say, again, let's sniff them again. We sniff them again. Their anxiety level goes up, and then they don't go into, we have another violation of expectation. So high distress, violation of expectation leads to learning.
So in other words, I expected something bad to happen. That bad thing that I expected to happen did not happen. And as a result of that, I now changed my cognitive expectation or my expectation.
Yes, exactly. You asked me earlier about the thing I always say, and that is that if you change the B, you'll get the change in C for free. I can try and do cognitive identification and modification with a kid who has elevated fears about food allergens or elevated fears about dogs or elevated fears about separation from parents. And they can tell me all of the stuff while they're not anxious. So they can say, I know that if I'm away from my parents, the chances of them getting kidnapped and me never seeing them again are slim to none, under cool conditions, when they're not aroused and anxious. But in the moment, they will cling to their parents because when they get anxious, they have a hard time accessing that cognitive learning. If we do gradual exposures to separations from parents, and we increase that separation, and we even do some overlearning where we have parents deliberately be late to pick the child up, we let the child know in advance, and then later on, we get even better at that. We don't let them know in advance. They will learn, oh, when I'm not in the presence of my parent and I'm anxious, it turns out over and over that that outcome, them getting kidnapped or something bad happening, didn't happen. Meaning all we did was do exposures. We didn't do any cognitive work, but we got the cognitive change for free. Nothing bad happened.
So let me bring this back to the PRN medication issue. Imagine that patient with severe social anxiety disorder who's terrified to go into a restaurant, let alone order their own food. Let's say I use a small dose of clonazepam, and that patient is now able to go into the restaurant and is then able to order a glass of water or order part of their meal. In doing that, I've created a violation of expectation that something bad was going to happen, right? So did I just perform medication-assisted violation of expectations? Or am I just trying to rationalize something here?
No, Jeff, you're a genius, and that's exactly what you did. You're a genius and you're a healer. Look, if we get that kid in the door and she orders for herself and the food comes and she's taken a little bit of that clonazepam, great. And then if we get her to do it again with less clonazepam, even better. And then if we get her to do it again, this time with no clonazepam, and the food comes, and it's lovely because food is joy, even better than that. And then if we get her to go to a different restaurant and have her order again, now we're cooking, right? Now we're talking.
So it does make sense, kind of this way that I'd kind of conceptualized it.
Yeah, I like it.
Let's talk a little bit more about something I don't like to talk about, which is this whole idea of homework. I hear from all of my psychology colleagues that homework is really, really, really important. And as you know, I have 10-year-old daughters.
Lovely.
I hate doing homework with them. They hate doing homework. I hated homework when I was 10 years old as well. But as part of successful CBT, we need kids and their parents to do homework outside of our sessions. How do you make that happen?
Yes. All right. First off, I hate school homework as well. You are preaching to the choir. But I love exposure homework. And the reason I love exposure homework is that we're generalizing the learning that took place in the therapist's office to ecologically valid settings, aka where the child actually lives. I do not expect any child, I don't expect any teenager, and I don't frankly expect any of my adults to do their exposure homework for free. To expect an 11-year-old to go home and self-direct her exposure homework is to not be sensitive to basic developmental considerations. People don't like doing scary things. My policy is that I have parents present in sessions so that they can see how exposures go. I can train them to be deputy exposure therapists. And then I get to send them home.
I like that term.
Deputy exposure therapists.
I love it.
Yes. And then I can send the family home knowing that the child is going to do the exposures in the presence of parents, that parents are going to make them happen. And one of the things I say to reassure the parents is your child doesn't have to be into this. They don't have to like doing this. They can be mad at you. They cannot want to do it. But as long as they do their exposure homework, those violations of expectations are happening and the learning is taking place and they will be getting better. And this also applies to rewards. I don't expect kids to do scary things for free. I'm a good behavioral psychologist. I add rewards to doing the exposures. A lot of my anxious kids are so anxious and eager to please, they'll do their exposure homework for free. They don't need a reward. But I'm a good behaviorist, and rewards are feedback, and rewards enhance learning. So I will have parents reward their kids for doing their exposure homework with whatever is an appropriate reward for the family. And parents will sometimes say, I don't want to bribe my kid to do their...
That's exactly what I was thinking.
Yes. And I say, well, a bribe is something where first you give the prize and then you get them to do the thing, right? So here's $10,000 and now here you go vote the way I want in city council. Or here's $10,000, now you go throw the fight, prize, boxer. The reason that bribes don't work is that people are now under no obligation to do the good behavior because they already have the prize. Whereas a reward is first you do the good or helpful or healthy behavior, and then you get the prize, and that's called a paycheck, and adults rely on rewards all the time. So with parents, I say the following. If you're going to have a hard time getting your child to do the exposure homework, she's not going to do it for free, then you really do need to rely on rewards. And it doesn't matter if the only reason your child is doing the exposure is to get the reward, because she's still doing the exposure and she's still going to have that enhanced learning and get better.
So what are we talking about reward-wise? What are we talking about?
Oh, I think rewards can be anything. I think, behavioral therapists love to set up reward menus with families where it's a shared positive experience. If you do your separation anxiety exposure homework 3 times a day, you go to the bathroom by yourself and you don't insist your parents go with you. Then you can save up chips and buy a bike ride in the countryside with your parents. That is great because relationships are built and maintained on shared positive experiences, as you know. But look, I'm a realist as well as a good behavioral psychologist, and from my mind, rewards have to meet 2 criteria. They need to be truly motivating for the child, and they need to be feasible for the parents. For example, money. Money, if it's feasible to the parents, is a great reward to kids because kids are often motivated by cold, hard cash. Another would be an Amazon wish list. So go and have your kid quickly create an Amazon wish list for 5 to 7 things that are $5 and under and a couple things that are $10 and under. And then the second they meet criteria, meaning they have done their homework, whatever was assigned, they can run and turn that in, and it can, it can arrive magically the next day, right? That's also a great reward. So for the parent who doesn't want to bribe their child, I first say you're not bribing, you're rewarding. And the other is that parents will say, I don't want my child to get addicted to rewards. And I say, right. The nice thing about anxiety is that what your child is avoiding almost always is something that is going to give them joy later on. If your child is avoiding school, going to school and being with friends and accomplishing things is going to be rewarding. If your child is avoiding separating from you and she's 9 or he's 11, once he learns to tolerate those separations, the whole world opens up because he gets to have alone and independent time from parents. So rewards themselves, reward charts, in the case of anxiety, will fade. They will die a natural death because after a while, those behaviors become self-reinforcing for the child.
So true, so true.
It is.
So Most of my patients are in psychotherapy. And one of the issues where I practice, and I suspect this is the case for many of our listeners as well, is that there are always new therapists coming onto the field. And it's pretty common for a patient that I'm seeing to be working with a therapist that I don't have an existing relationship with. And I often try to get a sense of what's happening in psychotherapy, even if I'm seeing the patient in the context of a med consultation. Of course, down the road, I'll talk to the psychotherapist, but it's often very difficult for me to assess what's happening in the session. We talk about anxiety. The therapist asked me about stuff. We talk about school. And we
talk about my friends.
So how do I know what's really going on? Do you have any tips for us as prescribers as to how we can assess the quality and the general tenor and type of the psychotherapy? In other words, is it CBT? Is it good CBT? Is it CBT that's working? Is there a viable alliance? Are the parents involved? How do we know these things?
Yes. I recommend the following. The first is to ask, what exposures are you doing in session with your therapist?
What do you mean exposures, Dr. Dahlsgaard?
Bravery challenges, stick tasks, facing your fears.
I don't know what any of those words are.
Oh my goodness. I'm going to have you step out real quick because I'd like to talk with your parents. And then I need to talk with parents. If a child has a bona fide diagnosed anxiety disorder, they should know what an exposure is because they should be doing it with their therapists. Exposures are the evidence-based active ingredient in CBT. Not only should they be doing exposures, but they should be doing them in session with therapists. I hear that a lot of therapists will assign exposures for at home, but never complete them in the office. And that's a problem because high distress is better, and that's what exposure therapists do well, which is we work with children and their parents to do high distress exposures. Maybe not in session number 1 or number 2, but pretty rapidly moving up the exposure hierarchy, even if we're even using one. So the problem with just assigning them at home is that they never end up being distressing enough.
Wait a second. You said if we're using a exposure hierarchy?
I did, Jeff. I said it. I said if using an exposure.
I was taught that was the first thing you do. You establish some hierarchy. Is that not true anymore?
Look, most of us do establish a hierarchy because and a hierarchy for our listeners is when you ask a child, hey, if we whispered the word vomit, how scary would it be 0 to 10 or 0 to 100? If we shouted the word vomit, how scary would it be 0 to 10? If we had a gagging contest where we did gagging, how scary would that be? If we ate yogurt that had expired the day before, how scary would that be? So I like to build the exposure hierarchy because I like to know what is highly distressing for a child and how their anxiety talks to them in the context of building that exposure hierarchy.
But you're saying that's not needed.
Apparently, it isn't, and this is according to Krask's research. You know what? You can mix and match. You can start with day 1 doing a high distress exposure, and then later on doing a low distress. You can mix and match willy-nilly.
Is that better? Is it worse? Or is it just doesn't make a difference?
Per the research, it doesn't make a difference. The learning happens anyway. So what I find as a therapist, I still use an exposure hierarchy, again, because building it with the child and the family really helps me to understand all the islands of fear and really the islands of avoidance that is going on for this kid. In other words, the functional impairment. But then the mixing and matching and knowing I don't have to work up methodically up an exposure hierarchy step after step after step is quite freeing because it does allow for creativity in sessions. Like, oh, there isn't any expired yogurt, so we can't do that today. So whoops, onward to the gagging contest. Let's bring it on.
So back to how do you actually assess what's happening in psychotherapy? And quite frankly, every kid that I have ever seen who's in psychotherapy, when I meet with them, you know what they tell me? They tell me, we're doing CBT. And then about 3 minutes into the discussion, I find out, I don't think they're actually doing CBT. So how else do I assess that other than looking for the exposures?
Jeff, I will be honest. Look for the exposures.
So it sounds like that's really what I need to focus on. Look for the exposures, then I look for the exposures. And then if I haven't found the exposures, I really need to do more digging and make sure that there aren't hidden exposures that I've missed.
Good luck. Research says that only about 10 to 30% of CBT therapists for anxiety do exposures in session, actually do them. So exposure therapists are a rare breed, but we shouldn't be because, again, exposure is the bona fide active ingredient in the psychotherapy in CBT.
So let's end with the hardest question.
Oh, no.
So
I'm feeling a negative outcome. I'm feeling catastrophic. It's going to be the hardest question I'm not going to be able to answer, and I'm going to ruin this podcast.
Lie number 2 still.
And also, I'm just going to melt down, and I'm going to lay on the floor, and I'm going to cry.
Lie number 3. Bringing it home. So, Ian.
Wait, are you about to do an exposure?
Perhaps.
You're a genius and a healer.
So, Dr. Dahlsgaard, what would you recommend if I am the prescriber and I get that sense that there's really not actual CBT going on in the sessions with the therapist? And by the way, this is the only therapist that's available because where I practice, like where most people practice, it's going to take 6 months to get into someone else. What do you recommend I do? How would I frame that conversation with the psychologist treating the patient or with the parents? What would you recommend?
Look, this is going to have to be me functioning while anxious. And it is as follows. It is a sad fact of our healthcare system that there aren't a lot of exposure therapists out there. So you have the following options. One is you can say to the parents, if your kid is getting better with this therapist, great, right? I don't want to be a killjoy here. I want to be real. And if a child is getting better with a therapist and they never do an exposure, wonderful. But if the child is not getting better and is also not getting exposures where exposures are needed, then a sit-down talk with the parents about any of the emerging online psychotherapeutic or digital therapeutic outfits where they do actual exposures would be a reasonable thing.
So it has been an absolute pleasure to spend the time talking with Dr. Dahlsgaard. And as always, I have learned a ton about how I can incorporate CBT and specifically exposure-based principles into my prescribing practice and in terms of how I can change how I think about medication and perhaps how I look at prescribing through a different lens. Thank you again so much for being with us. I'm sure our listeners appreciate this as much as I do. Again, thank you so much, Dr. Dahlsgaard.
My pleasure. Thank you.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.